we're going to spend this time to talk about the proper way to perform endotracheal intubation. And the name is called name of it is DL intubation. DL is direct laryngoscopy, right? And what that means is that you are visually have to see the structures. There's no video instruments. There's no like a video laryngoscope that you guys have right now, right? So we're going to visually see. If you see these types of pictures, right, where they have, right, this guy performing the procedure, he has no PPE on, has no face protection, right? He has the sunglasses, right? It looks cool. You're going to be doing none of that, right? So none of this, right? And so we're going to talk about the indications of intubation. So indication means why are you performing said procedure, right? So let's say if I ask you for, let's say, why are you giving oxygen, right? You're not going to say, oh, just because, you know, it says in my protocol. You will say, okay, person is showing signs of hypoxia, their saturation is 89%, and they have dyspnea, right? So they have poor oxygen saturation means we can help them by providing them some supplemental oxygen. Make sense? So the indication was hypoxia, low pulse ox. So the indications for intubation is not because I can, it's not because it's in my protocol. So it's the following three criteria, right? So it's failure to protect and maintain airway, right? Failure to oxygenate or ventilate, and expected clinical course. I'm going to go through it, right? So failure to maintain or protect, right? So if a patient has a failure of either one, right, they will need to be intubated. So I'll give you some examples. Let's say you have a patient, right, who you come on scene, right, and you start to assess their airway. You notice, right, they have a lot of vomit and they look obtundant. They're unconscious, right? They have their muscles of the tongue, the genioglossus muscle, right, is relaxed, it falls back, right? So that patient on your assessment, as you open the airway, right, you see the vomit, right, you see the tongue that's falling back. Can they protect or maintain? No, they cannot, right? They cannot. You may have another patient, in a nursing facility, right? You come in, you assess them. For example, you open their mouth and you see secretions pooling, right? They cannot swallow. Right, and you give them some water, and you see the secretions pouring. Or when they feed them, they cannot swallow. Right. So again, right, they have a failure to what? To protect and maintain. Because if they cannot do that, and those secretions go down to the trachea, they're gonna get what? Aspiration. And what's the problem with aspiration?
Goes into the lungs.
They swallow. They drown in their own.
Yeah, it goes into the lungs, and you may have pneumonias and infections, right? So let me go step by step for this, right? So the first one we talked about determinacy of the patient. So we said failure to protect or maintain, right? In a lot of the books on EMX books, they say gag reflex is a good indicator of airway protection, which is false. There's no studies that show that. And in the patients who is obtundant, and you try to, let's say, elicit gag reflex, let's say you're trying to, see if gag reflex is the protective mechanism, and you elicit it, what the patient likely to do? Vomit. And you have now unconscious obtundant patient who vomits because you try to elicit the gag reflex to see if they have good airway mechanics and protection. And what happens with that vomit? Aspiration, right? So gag reflex is a poor indicator, right? What is the best indicator to know that the patient has patent airway and they protect it? Is they have ability to phonate. Phonate means they make sound, they speak, right? And they're able, if I'm talking to them, I'll say, hi, my name is Nicola, I'm paramedic, where's your name? Right? She's able to interpret the information and tell me the answer. So she's able to make sound and interpret. So she has good perfusion to the brain, right? And more importantly, she has protective airway reflexes because she's able to tell me that. And then the second thing we want to do is we want to see, can you swallow, right? Can you swallow? And if they're able to do that, they're able to initiate, right, the muscles of the upper airway to do that. And by doing that, the epiglottis, right, is the structure that closes the trachea, will close it, and then they will be able to swallow. So having the patient or, someone you are attending to do those two things, then I can reliably say they have a patent airway and they're able to protect it. So one thing is what? Phonate, make sound, right? And the other one is to swallow, right? If the patient cannot protect their airway, they need to be intubated. If they cannot maintain the airway, they need to be intubated. We usually say, right, if they cannot maintain the airway, they cannot protect it either, right? So protection and maintenance has to be together, right? And the way we talked about is phonation, right, and volitional swallowing. Volitional means on their own accord. They're able to do it if you ask them, right? So these are the determinants of the patency. The next thing we talk about oxygenation and ventilation. So those two things are not the same. I can give you an example of a patient, right, you encountered who has congestive heart failure, right? And let's say for the time being, they have protection of the airway, they have maintenance of the airway, but as time goes by, their lungs is filling up with what? Edema, right? So do you have good oxygenation? Can the oxygen diffuse, right, through the alveoli to load on the hemoglobin?
No.
It cannot, right? So if it cannot, they have failure to oxygenate. We call it type 1, right, respiratory problem. So we need to, the reason we're intubating them is not to protect or maintain the airway. The reason we're intubating them is because what? Because they have failure to oxygenate. You follow what I'm saying? So we need to provide them oxygen, right, with some PEEP, right, on the ventilator, what we provide with them, right, if non-invasive things are not working. So we tried non-rebreather, we tried the CPAP, not working, right? Saturation is still down, right? They're starting to become altered, right? And they have fluid. So we intubate them, right, because they have failure of oxygenation. And then another example I can give you have a patient like status asthmaticus or COPD patients, right? Their problem is, right, they are laboring on the, remember we talked about for normal respiration, when you exhale, it's a passive process. But for these patients, the passive process, right, is no longer passive. The exhalation is no longer passive. They're going to labor to exhale. Why they're laboring? Because they're retaining, right? So they're going to have bronchospasm, right? And they're going to use their abdominal muscle, intercostal muscles, right? The diaphragm, right? They're going to have pursed lip breathing, nasal flaring. They're going to have tripod position to blow that air. So they have failure to ventilate. They cannot exchange, right, air. I don't know if any of you seen this device, asthmatics care. It's called a peak flow meter. It looks, it's like a white device, looks kind of like that. There's three zones: red zone, right, yellow zone, and red zone. So green, yellow, red. And when they have that asthma attack, they tell them blow on it, and if that dial barely moves, right, let's say you're in the red zone, right, they tell them take your rescue inhaler, call 911. So it means you have severe bronchospasm. So you cannot ventilate, you cannot move that air. You follow what I'm saying? So those patients, we intubate, not because they have failure to maintain or protect the airway. We intubate, they have failure of ventilation, and want to ease the muscles of respiratory system. So we intubate them and we give them certain drugs to bronchodilate, right, and basically help them. Yeah. The other example they give you here is ARDS, right, or you guys been exposed to COVID patients, right, where their lungs are basically filling up with infiltrates, right? It looks like glass opacities on the X-ray, right? It's all fluid, infection, right, and all the stuff coming in, and they have destruction of type 2 pneumocytes that make surfactant. So those patients with COVID, they have destructions of type 2 pneumocytes. Surfactant is a coating on the alveoli that keeps it open. It's going to collapse. So alveoli collapse, fluid in the lungs. What's going to happen, right? You can't oxygenate, right? So all those things, right, we're going to intubate them. And the final one is expected clinical course. Before I go through it, right, so the third one is expected clinical course is to decline, right? And a lot of you who are doing transport, you're going to encounter this quite often. I encountered this almost every time I did my transport. So you may have a patient who has no problems protecting or maintaining airway. And currently at whatever they have them on, like let's say CPAP or BiPAP, they're able to oxygenate and ventilate. But what I'm saying to you is clinical course is to decline. So we're intubating them not for any of the first two. We're intubating for choice number 3, right? And who give me an example of a patient like that? So you go to a facility, right, and you think their clinical course is to decline.
Say that again, you go to a facility?
Yeah, you go to a facility, you have a patient, right, who doesn't have a problem with maintaining or protecting the airway. Currently, let's say they're on CPAP or BiPAP, and they don't have problems with oxygenation and ventilation, their pulse ox is good, but you anticipate their clinical courses to decline. So you say, we want to intubate them, right? Give me an example of a patient like that.
Septic.
And why would we intubate them? Why are we intubating them? The doctor says, he comes to you, he says, he's fine, look, he's maintaining, he's on BiPAP, he set this 99%.
Because the second they take him off of that, he's fine.
They say, you brought your CPAP, put him on, take him.
He's on oxygenating properly.
So this is the cases you're going to encounter as paramedics, and you're going to make those decisions, right? So what I'm telling you is this. You have to be cognizant, you have to assess the airway, right, and their breathing. So you come in, let's say your transport is 45 minutes or 50 minutes, and you have an EMT who doesn't know where they're driving, right? They're going to take you to scenic route, right? And it's going to take you an hour, right, to get around. You come in, you have a patient who is on BiPAP, he's breathing 34 times a minute. He's laboring already, right? He's already sitting on the stretcher like that, right? You assess his skin, right? He's diaphoretic, right? His pulse ox is labile. The moment you start to remove that mask, he saturates quickly. Do you want to intubate that patient in your back of the ambulance when you're by yourself and you're driving? No. So when is the best time to intubate? In the hospital setting where they have the paralytics, they have all the video laryngoscopy, so it's safe to do so. Right? Another example, so that's one example to give you, right? Another example could be, what if you have somebody who inhaled superheated gases? Right? Right now they have patent airway, they protect it, they don't have oxygenation or ventilation problems, but what happens as time goes by? They're going to swell. Edema, right? So do you want to intubate that patient when it's all swelled up? No, right? So we want to do it early. Another example in the hospital, this happens quite often. They take a patient from the ER, they're on oxygen, they're sitting up, they take them to the CT scan. What happens in the CT scan? Laying flat. And right, they call a code, right, in the CT scan, right? So the expected clinical course, right? So some examples they give you, right? You have first guy is a trauma. You have a stab wound to the mid-zone of the neck, right? And there's expanding hematoma, right? The blood is there. So we want to intubate them early before it becomes a problem and it's going to distort your airway, or your blood pressure drops and then you cannot get vascular access, right? The other one I told you, right? Increased risk on the patient's transport, right? Hospital to hospital or to the CT scan. And we talked about the facial burns, right? Superheated gases. So just to sum up, what are the three things that are indications for intubation is what? Failure to protect or maintain, failure to ventilate, oxygenate, and expected clinical courses to decline, right? Do you need all three?
Yes.
No, you don't need all three. You do not need all three, right? One criteria is sufficient. If you have all three, you better intubate them.
Oh, I was gonna say.
You stop having choices.
Right? If you have all three, you better intubate them, right? So remember we did pre-oxygenation. I'm gonna use you again, right? Well, for this, I actually put up another pulse ox. First thing we're gonna do, right? Once we're gonna, we're gonna. I don't need that information. Right? So, first thing we're gonna do are ABCs, right? For every patient. The moment you determine there is, they have airway compromise, right? They have failure to oxygenate, ventilate. You're going to start with your BLS procedures. By the way, I'll say the BVM ventilations, the BLS procedures, is the most important. It's not the intubation. Most paramedics, EMTs, doctors cannot do this right. I'm going to go through how to do it right? So it's the vital thing you're going to do, right? And then as you assess that, right? Let's say you determine it's a high priority patient, right? You want to intubate them, you're still bagging them, right? You move them to the ambulance, you're going to put them on your monitor. When I say put them on the monitor, you're going to put everything. You're going to put your EKG leads on, you're going to put a pulse ox on, you're going to put, right, the end-tidal CO2, the one that he was holding in his mouth, between your mask and the BVM, and you're going to put this monitor where you could see it, right? It's not turned to the side, where you could see it, right? And then I usually turn on the audio, right, the audible alarm, so I'm hearing and seeing, because if I start to hear my DSATs, I want to hear it. If I hear my heart rate elevate, I want to hear it, right? So put them on the monitor, right? We talked about oxyhemoglobin dissociation curve, right? So let's say you arrive to the scene, right? You decided you want to intubate. You tell the BLS providers there, hey guys, I would like you to pre-oxygenate this patient to 100% pulse ox. And they're over here, right? We heard you, right? No problem. I look at the numbers. What's the problem? And what's the problem? Left shift. What's the problem with left shift?
They hold on to the oxygen.
CO2 goes down.
CO2 goes down, right? So you're going to move here. So you see it's going to get, so at the bottom is the amount of PaO2, partial pressure of oxygen, is going to release. So you see you're going to left shift, you're going to decrease their PCO2. So at this number, let's say you're at 90, right? It's going to release way more oxygen as opposed to you at the normal value. Right? You see, at the normal value, you release more oxygen as opposed to your left shift. So now you understand. So what the corrective action you'll tell them? Slow down.
Slow down.
Right? I want to see end-tidal CO2 there, 35, 45, one breath every 5 to 6 seconds, right? Probably towards the 6-second mark, right? I personally tell you when I'm about to intubate, I do the ventilation myself. I let them squeeze the bag, but the motion of airway maintenance, I do it, right? The skill is the mask. The bagging is not the skill, right? So this is what I was trying to explain to you during the lecture. Here you have safety, right? You have time. The moment you get to 90 saturation, right, your pulse, your PaO2 drops suddenly. Why? Because your tissues are craving that O2, and they're gonna take as much of it as they can. From here to here, you may have minutes. From here to here, you have seconds. And the other problem is this: if your patient has low cardiac output and they're shocked, your pulse ox is lagging. So the pulse ox that shows you, let's say right now it's 95, right? It's maybe in the past. right? The current they may be at 89. You don't know that, right? That's why I say at 92 you should be very mindful. So we're gonna pre-oxygenate them for 2 minutes, and for this skill, this is very different. All the instructors, I want you to listen. They are to do this for 2 minutes. They're gonna bag. They're gonna use that technique for 2 minutes that I'm showing them. They're not to bag one breath and you say, okay, the pulse ox is 100, right? They're gonna bag for 2 minutes, and if their technique, right, is not proper, you're gonna correct them, right? And if after the correction they're still not able to do it, they're gonna still practice. They don't get a pass, right? They're gonna practice until it's right, 2 minutes, and your partner is gonna stay there in time. Question: why do we have to do this for 2 minutes?
Because you have to
Let me get one person answer. Yeah.
Because you have to get used to it while you're out there. You have to pre-oxygenate 2 minutes. The requirement.
Why is 2 minutes?
CPR.
No.
No,
Patient
because-
patient has a pulse. Yeah.
To bring their oxygen level up to 99 to 100% and denitrogen them.
Excellent. Excellent. Right. Because normal air we breathe is 78% nitrogen, 21% oxygen. So when we start 100% oxygen, we're going to remove that nitrogen from the lungs. We're going
And you
to
take
basically
2 minutes.
put all 100% oxygen. We have to do it for 2 minutes to do two things: drive their pulse ox to 100 and denitrogen the lungs. This would buys us time. If you give them a couple of breaths, 30 seconds in, their pulse ox is 100, you still did not fully remove all the nitrogen. That's why we do it for 2 minutes. You guys understand that now? Right? So 2 minutes. Yeah.
So, in one of your videos, you talk about nitrogen washout.
Yeah.
Is that what you mean by the nitrogen washout?
Yeah.
You're completely fresh from the system.
Correct.
without nitrogen.
Correct. You're removing the nitrogen, the 78, and you're replacing it with 100% oxygen. Yeah, that's why we put them on oxygen, right? And we don't want them to become hypoxemic. We want to have our eyes and ears, right, on the pulse ox. The moment it gets to 92, you're going to stop what you're doing and you're going to go back to what? Pre-oxygenation for how long?
2 minutes.
Excellent, right? So this is what I was explaining to you, right? Here you have time frame, right? And the instructors before will tell you 30 seconds. You don't have 30 seconds. I'm going to show you true numbers, right? But here it's a very brief moment, and then they decide. This is how they get hypoxic brain injury, right? If you're at 90, you better stop doing whatever you do. Even if you see the vocal cords, you stop. You go back to oxygenation, right? You're going to kill the person. How are you going to kill him? By hypoxic brain injury, right? And give me a second. No, it's not going to.
What do you do better?
No, probably.
What size?
I'm going to just run it for now.
It's
Alright.
triple A's?
Yeah.
Okay.
So this is the chart they did in anesthesia. I'm going to have a little bigger picture to show you guys, right? So what they did was they gave these guys succinylcholine, and now you guys should be experts. I want one person raise their hand. Tell me how succinylcholine works. One person raise their hands. I see your hand. Go ahead. I see. Depolarizing neuromuscular blocker. How does it work? Binds to which receptors? Huh?
It binds to the
Nicotinic cholinergic receptors, right? And it stimulates it, right? So sodium goes in and depolarizes. That's why you see fasciculations. And then we talked about the non-depolarizers, right? The rocuronium, pancuronium, vancuronium, curare drugs. How they work?
It's the same thing.
No. They block the receptor. So you have flaccid paralysis, but no fasciculations, right? Very good, right? So what they did was they took healthy guys, some sick guys, some fat guys, some kids, right? And what they did was in anesthesia settings where there were people, anesthesiologists, who were trained providers how to do the airway, right? And what they did was, right, they gave them succinylcholine, and then they saw, right, how long it takes for them to get to the 90 mark of desaturation, right, to know, right, what's the real time. So let me blow up this picture so that you see, and then we're going to show you all these numbers, right? Right? So here, this is 100% saturation, and we're going to look at this point, right, where it says 90. Why 90? Because at 90 is where you should stop and go back to what? Pre-oxygenation, right? So look, let's go at 90, and we're going to go to the healthy person first. Normal person, 70 kg, right? How many minutes it took for desaturation to occur? 8 minutes. So if your technique is good, and you do the techniques I show you, and you pre-oxygenate for 2 minutes, do you have 30 seconds? No. You have almost 8 minutes, right? But the patients you're going to get, are they going to be healthy?
No.
All right, so we're going to go to the, let's say, the moderately ill, right? At 90, right? What is it? 5 minutes, right? Still not 30 seconds. Let's take a child, right? We're going to go, so this is a normal child. We're going to go at 90, right? 3.5, let's say, right? And then let's say the person you're gonna get is this obese patient, right? And we're gonna go to this 90 mark, and we're gonna go down, right? You have a little over 2 minutes. So at no point do you have 20 seconds. But what they don't tell you on this graph is the people doing this procedure are trained anesthesiologists whose technique is flawless. Why is the technique flawless?
They do it too much.
They're by themselves. And if they fail, they push all these drugs and they cannot ventilate. What happens to the patient? They're dead. And what happens to the doctor? Yeah. So now if I took $500,000 to go to school, 10 years of my life, do I want that to happen? So I make sure my technique is what? Flawless, right? And your technique is going to be flawless because you're going to practice, right? Doing it. Thank you, Joe. Right? And right. So now we know the time frames. So we're going to say their patients, if they pre-oxygenate right for 2 minutes, give them more than 30 seconds, right? Let's say we could give them between, we're going to say you got this obese person, we'll give them 2 minutes. So you have 2 minutes as long as you do your technique right. If you don't do your technique right, yeah.
Do you want me to get a CPR man out for each station so that they have something that's legitimately, like, kind of similar to bagging?
You can, yeah, that's fine.
This is too easy.
Yeah, you can. So now I show you about the positioning, right? So when you're intubating and ventilating your patient, the position is going to change. Sniffing. Yeah, sniffing. Excellent. Who said that? Who said? Come over here. Come over here. All right. Pretend. You're gonna face me. Pretend this is roses. You stay right here.
Sniff it.
Come, no, face me. This is roses. I don't want you to move your body. I just want you to move your head to sniff these roses. Stop like that. You see how she aligned her external meatus, right? The ear hole to the sternal notch. Everybody see that, right? This is, they say like this. This is the sniffing position, right? That you want to import. Thank you so much, right? This is the sniffing position you want to employ, but the caveat to that, only for patients who do not have cervical spine injury. Once we get to the trauma lectures, we'll explain to you the modification there. But for the patients you don't suspect spinal injury, that's the position you're going to take. So I'm going to show you some of the pictures here, right? How they use it in the hospital. So they put a stretcher and they put a roll right here. The goal is to align the ear hole to the sternal notch and the face is parallel to the ceiling. You see how the ear hole is to the sternal notch, right? Here, it's not aligned, you're not going to have good ear visual view. Here, you're not going to have the best visual view. And the moment they're in this position, right, they have good view. How are you going to do this on the EMS side? Well, first of all, let me say, why is this important? The reason this is important, you want to align the oral axis, the pharyngeal axis, your throat, and the larynx, right, the voice box, the laryngeal axis. You see how they all align when you elevate the head, ear hole to the sternal notch? So this is the position we're going to take. It also gives you a better way to ventilate them, so less air goes where? In the belly, and the air goes into the laryngeal inlet, because you align all the axes. You don't have to squeeze as hard, right? Makes sense, right? So this is an example, right? They put some sheets, or you could use towels, right, to do that, right? Ear hole to the sternal notch, again, no cervical spine injury. This is examples on the EMS, right? Here they use a stretcher, they just put some pillows behind the head. Ear hole, sternal notch, face parallel to the ceiling. Here they use some bunker gear and some fluids, right? Maybe you're on a call somewhere, right? I would use, you could use an oxygen bag, right, that you carry with you, or some other stuff that you have. Maybe, you always put like a sheet on the, a stair chair, right, that you bring up with you, right? So you could use those things. The other thing I want to tell you, right, I said this is the technique portion of it, the mask. I was showing you on pre-oxygenation, right? You're going to get the right size, and we're going to spread the cuffs, right? And you're going to put it on the bridge of the nose, and you're going to make sure you have a good seal. Why is this important? Why do I spread the cuffs? You see what I'm doing? Suction. Why is it important to get a suction? Seal, no air leaking, right? No lateral air leak. That's why this EC clamp technique is bad, because what happens on here? Lateral air leak, right? Lateral air leak, right? The other problem with this technique is this hand closes the mouth, right? And you cannot lift the mandible up. So this technique is the worst technique you could do, right? So I'll tell you why this is the worst technique, right? So I have a video about explaining one hand versus two hand, but I can assure you the two hand is the best technique. And here what I'm saying is, if I was by myself, I would still not use this technique. I would use this technique and use my arm like a chicken wing to do it, right? So here they did a study. It was done by Peter Safar. He was in Baltimore. He was one of the anesthesiologists, and he was like, they call him the father of CPR. He's the one who created that, called cardiopulmonary resuscitation. So he conducted all these airway studies that everybody seemed to forgot, right? So he said with the neck flex chain towards the chest, right? The airway is obstructed on all patients in both supine and prone positions, with or without the OPA in place. So let me show you his data. So you have this patient, right, like that. They put an OPA, right? So this position A plus an OPA. This is airway obstructed. This is airway partially obstructed. This is airway open. So those who believe your OPA opens the airway, how many of them had open airway?
0.
0. How many had obstructed? Pretty much all of them. So does your OPA open the airway? You tell me. It doesn't, right? So your OPA doesn't open the airway. So what actually opens the airway, right? So it's not the OPA. By the way, the purpose of the OPA is not to allow the operator from closing the mouth. So let's say if I had my OPA in place, right? The purpose of the OPA is not to lift the tongue out of the airway. It's not to allow you to do this. So you cannot close the teeth. That, right? So this is another study again, right? You notice the ear, right? So they said, even with the use of an artificial oropharyngeal airway in OPA, the pharynx is not kept patent unless both hands of the rescuer are held and hold the head in extension and support the mandible. That basically means you lift the mandible and you extend the head, right? And this was why this bad technique became so popular. So there was a study by right, Elam, right, head tilt method of oral resuscitation. They were trying to find ways how to teach people CPR, right? And what they said is this, right? It's very hard, right? The teaching may be summarized, right, as follows, right? Pulling the jaw with the thumb, right? Pushing upward on the angles of the jaw, involves numerous fine details in the technique which cannot be learned by some layman, right? And the average layman is unaware of the anatomy of the airway obstruction and has difficulty understanding or remembering it, right? So they were teaching CPR, right? But who takes CPR class? Everybody. I'm a medical assistant in a dermatology clinic, right? How many cardiac arrests I'm going to run? 0, right? Why should my training be equivalent to yours, right? So AHA is bare minimum, right? It's not even standard, right? For you guys, right? So they said, right, it's much easier to tell, right, to minimize, or right, the subject matter taught, just tell them, right, tilt the head back fully and then blow through their mouths and nose. This was before, right, they had the masks and all that. And, right, this is easy to teach. Tilt the head back, you blow, right, and it's good for a layman, right? Somebody who's going to do compressions and that's fine, right? And they say perhaps for the professional rescuer, they should be taught all of this, right? Perhaps, right? Perhaps. And so they need to know the airway supporting maneuvers, they need to know the anatomy, right? And you need the training to do it, right? So, but for the layman, it's not important, right? And so I'll show you some other studies that looked at all these methods, had position for opening of the upper airway, right? They say there's 2 basic maneuvers to keep the upper airway open. It's the hyperextension of the head and the jaw thrust, right? Described by Peter Safar in the 1950s, right? So the triple airway maneuver, right? And 50 years ago, right? And the combination of both of these, right, seems to be the most effective, right? And unfortunately, this knowledge is often lacking, especially in lay bystander. I'm going to say, not just lay, in professional providers, right, who are able to save a life quickly. So BLS skills for the most providers are not good, right? And you guys going to learn how to do it right, right? This was a study put out by an anesthesiologist, right? And he's saying 1 hand versus 2 hands, right? What are you saying? I therefore always use 2 hands performing triple airway maneuver during anesthesia induction. I advance the mandible with both hands in the ascending rami, right? This is the lower mandible, without touching the mandible body, right? Without closing the mouth. That Peter Safar said. And what did he say? I do not recommend the EC clamp mask holding technique to our anesthesia residents because it holds the mandible body, closes the mouth, and tends to push the submandibular region, right? Submandibular region, and you have a lateral air leak in that, right? This was another study again, right? What is superior, right? One-handed EC clamp versus the 2-handed, right? And right again, they say the triple airway maneuver, right? Advancing the mandible is the best technique, right? So they say consider 2-handed jaw thrust mask technique improves the upper airway patency and gives you greater tidal volumes and pressure control ventilation, right? Than the EC clamp technique. So EC clamp technique is the what? The worst technique. So when you're gonna be performing this, I don't want to see any easy climbing, right? And then they looked at this. This was another good study, right? They said which technique for two-handed, right? Because I see you guys come in two-handed, right? And you guys try to do this. I see some of you doing this, right? Right, versus this. So they wanted to see this versus this. Which one is better, right? So looking at this study, right? You see, right? So they looked at this versus this. So, right, comparison. And here's the study. They took 40 subjects, right? And in step 1, they start with the CE technique, right? And they said, right, 20 of them, 50% failed mask ventilations, right? All failed attempts at mask ventilations with the CE technique were successfully rescued with the V technique. So everyone who failed with that were successfully rescued with this in step 2. In group B, right, all 41 subjects starting with V technique were effectively ventilated in step 1, right? And they give you some data points, right? They're basically saying, right, though they started them off with CE, wasn't working, right? And then they switched to VE. Those who had VE all were successful. So this technique was shown to be what? More efficacious, right? And here you see, right, they have this is a obese patient probably, right? I see what? Compressions being done, right? Notice the technique, right? What is this thing here?
That's the
Inside
Anti-O, right? So now, are we going to be placing adjuncts? Yes, we are, right? They will assist us with ventilation. Usually I place an OPA and 2 nasal trumpets, right? Or nasal pharyngeal airways, right? So both of them, right? You're going to place when you're starting to do this, and then you're going to start to, right, ventilate them. How to measure? From the central incisors of the teeth to the angle of the jaw. And this one, right, from the nose to the earlobe. Right? We're not going to worry about this for now. I'm going to show you the best way to hold the laryngoscope, right? So this is not a handle. This is a battery holder. This is not a handle. This is a battery holder. So how are you going to hold this? You're going to be lower down, thumbs up. You guys old enough to remember the Rock'em Sock'em robots? You guys remember that, right? So lower down on that, on this, right? Thumbs up, and your motion is going to be like that Rock'em Sock'em motion. It's not going to be, right? It's going to be your wrist stays in place, right? So lower down, thumbs up. You're going to give me thumbs up, and then your chicken wing. You see how the arm is out? You're going to put your chicken wing in. This gives you better leverage. So thumbs up, chicken wing in, and you're going to give me the Rock'em Sock'em motion. Everybody follow? All right. Next thing, positioning, right? Ideally, right, in the EMS, we don't always have this, but if they're in the back of the stretcher, you want to position so that their head is between your belly button and your
Sternum notch.
non-sternal notch,
Oh,
the xiphoid process. Right? The belly button and the xiphoid process, right? So the head is right here. If you're able to right, pull up this stretcher, sometimes you can. You have to be in a lying position, right? They show you 2 techniques to open the mouth, right? I wouldn't recommend this technique because I don't want anyone to bite on my fingers, right? I don't know their level, so when I'm inserting the OP, my technique, the one I like to find their lip and I move their mouth down like that. You see where my hand is? I'm not on the teeth, right? So if they start to chomp down, right, my hand is not anywhere near on the teeth. And the technique they say is good. You may try this, but I don't think it's going to be super effective for you. But this technique that I used was effective. You start doing this, right? I mean, if you push your drugs and you know they're not going to chomp down, maybe guys in cardiac arrest, right? I'll say fine. But the moment they chomp down on your arms, right, you're not going to be too happy. I think Bob had that happened to him, right? So some of the positions, right? So you see here the paramedic is right trying to intubate. I would say the position is not great, but sometimes you have to, do this. This is in the lying down position, right? And then don't do this. Why? Because you have no leverage on the. You can't lift, right? What is wrong with this one?
It's all wrong.
Huh?
Oh my God.
It's all wrong.
It's all wrong, but I see this all the time in the field. You seen it?
Yeah,
Right, the reason why is you have a mobile patient. They're not. You think these guys are going to keep them stationary? The patient's going to go about. You're going to move your hand, right? Don't do this, right? Put some sheets. Put your O2 bag, right? Whatever you got, right? Put it in your fluids, right? Like this show. Don't do this, right? Now I'm going to talk about how we're going to position the endotracheal tube, right? So this is the tube. It comes in the bag. It's going to have a stylet, right? Do not do this. What I'm about to show you. You do not open the bag and you start doing this. What's wrong with that? No longer sterile, right? You contaminate. So what you want to do is you want to adjust. So if I can open the top, right? It's okay for you to hold here. But anything I do here isn't going to be in the packaging. So I adjust it in the packaging, right? I adjust, and I want it to be like this hockey stick position, not this band. Why? Because here, and we're going to hold it like a dart, right? Here I have fine dexterity. If it's like this, see how it's moving, right? You don't have no fine dexterity. So it's going to be straight to cuff. The stylet does not extend past the Murphy's eye, right? Do I test the balloon? You can, right, in the package to see the integrity. So what I mean by that, the balloon you're going to inflate. You're going to put air in here, and this cuff is going to inflate. You see that? This is not an anchor, right? This is just to make sure the tube is in the right place and there's no secretions going to go behind it, right? Less chance of aspiration with this tube. This is not an anchor, right? It doesn't keep it in place. You push air. You do not push saline in it, right? Air. This is a stylet, right? You could adjust it. And then if you needed to put water-soluble lubricant on it, right? I would do it again, right? While it's in the packaging, right? You could open up like so, right? And you don't need to dab a lot. You don't need to put it all over it. You just need a little bit at the bottom, right? And then I usually have it in the package. And what I do is this. I would have whoever is my partner or any BLS provider, I'll have them hold it and I'll say, right, stay by my side. The moment I see my structures, I do not want to take away my sight. I grab the endotracheal tube from the package. Everybody follow? So we'll do that. Talked about that. So the way you hold it is, you see how it's like a dart, right? You're gonna hold it like a dart or like a pen, right? Do not hold it like that. We don't jam anything. No, and no. Yep. It's a fine motion, right? Patients has what? Soft structures. I don't want to damage anything. If the vocal cords are shut, they have laryngospasm. Are you gonna plow your way through?
No.
Do you have drugs to break the laryngospasm?
No.
No. Which drugs break laryngospasm? Suction pulling or glycerol? Very good.
They don't have it.
Which you don't have. Very good. Right. So this is just the pictures. I'm going to show how it goes. Right. So once I instrument the airway, this is the view that I want to see. See, this is the vocal cords. This is where I'm placing the tube. Right. This is a grading schematic called Cormac-Lohim grading. Right. So you may have a patient. You go in. This is the view I want to see. This is a grade 1. Excellent view. This is, even with all the good positioning and everything, you may have this type of airway. This is Cormac-Lohim, right? Grade 2. Right. So you see, right? It's a B. Right. Grade 2. You could only see the epiglottis and just the laryngeal inlet slightly, right, with a notch. We'll talk about some of the techniques you could use. Not going to be today, but I'll explain to you with the gum bougie how we could use that. And this technique, you may try gum bougie, right, may not be successful. And this technique, you're probably not going to get an airway. They're probably going to need a surgical airway, right? They're going to cut the neck. It's called FONA, front open airway access, right? Right, so you could probably get access here. It's going to be very hard here. You will not be able to get access here without surgical intervention, which you cannot do. Right? I have a video, right? You guys, I'm not going to show it, right? You can go to the channel and watch it yourself. The difference is this. Why I show it is because that video has the screen where you could see the structures. When I do the demo, you're not going to see this. You're not going to see this. But any of you watch this? Yeah, you watch this, right? So. Right, next time, this is called a gyroscope. It's a video laryngoscope, right? And then, once the tube is in, I'm going to talk about the confirmation that we're going to do. There's two ones that you're going to need. I don't want to hear misting, bubbling, something like that, right? There's two confirmations. Confirmation number one, you have waveform capnography. This is numbers, so it's what?
35 to 45.
Yeah, 35, 45, and more importantly, you want to have an objective data. This is objective. Right? I print a strip, I know my tube was in if I have 35, 45. The next thing I want to do is I want to get long sounds. I auscultate right and left. Why do I need long sounds?
Make sure
Into
you're in the right space.
the lungs and out to stomach.
That is not the answer. That is not the answer. Why? Because I saw it go through the vocal cords. I will never listen to the belly sounds.
To confirm that you didn't go farther into.
Excellent. Say it louder.
To confirm that you didn't go further down.
What happens if you go? What if you go too far down? You're going to be where?
Right
Right.
wing.
Very good. So the reason you do long sounds is not to listen if they're wheezing or they have whatever long sounds. I listen right on each side, left and right, right. listen about at my mid-axillary line, right, on both sides, not anterior, right, mid-axillary line, because I want to hear left and right. If I put it too far down, I'm going to only have right side, right? And you want to be cognizant at the depth. So when I'm putting this in, I'm looking at the depth. It's roughly 3 times the diameter of the tube. So if you're using an 8.0 tube, 8 times 3 is 24. 7 times 3, 21. So roughly you want to be 3 times the diameter of the tube. If you said I have a 7.0, and instead of a 21, you're at 25. You're probably right brainstem. You're probably right brainstem. What's the corrective action? You deflate the cuff, you pull it back to 21 where it should be, re-inflate, reassess your lung sounds. Everybody follow? So the reason we do lung sounds is to make sure we have left and right. The reason I don't auscultate epigastric sounds is that I never put anything in unless I see this. I never put anything in like this. I never put anything in like this. I only put stuff in like that. That's why I never listen to the belly sounds. You will never see anesthesia listen to the belly sounds. Right? And I'm going to show you the technique. We're going to go structure by structure. You're not going to jam the blade all the way in. You're not going to do this right all the way in and lift. You're going to go structure by structure. We're going to find the epiglottis, molecular. I'll explain all this, right? And so lung sounds, end-tidal CO2, and pulse ox, your confirmation markers. So if I was documenting, I would say patient was intubated with 7.0 tube, 21 centimeters of the lip. Patient's end-tidal CO2 was, 32. Patient saturation is 99% on the pulse ox. Left and auscultation of bilateral lung sounds is positive over the mid-axillary line. And I print the strip at the time frame I did it. And another tip, if you're doing a transfer, you got a patient on cardiac arrest, right? You transfer them over. Make sure you print the strip. You show the doctor when we transfer into the stretcher, we had everything done. You print the strip and you have them sign. If they don't sign, just say, can I look at your card? Dr. Smith at the bedside, 2310, tube is in place, end-tidal CO2 32. Then you disconnect. Everybody follow? Mm-hmm. I'm going to show you the procedure so that you guys can see it. Right, if you guys are able to see it. So if you guys want to come around, I'm going to move this forward. Mr. Saulo, I need you for...
No, it's not just talking.
Sorry.
You're the VIP too.
Superstar's coming through. Excuse me. Hey, wait. No.
You know, she's probably right.
It's like patient coming through.
I did my hair for this show.
That's what she told me. Put the pulse on.
It's okay.
You sure you do your legs too?
Yeah, I did my legs for you, my guy.
I like that.
I lied.
You did.
I gotta go to the barber shop.
You poking your necks.
Yeah, I ain't poking me. I'm sorry, I don't trust nobody. Not even when I go to the doctor, they touch me.
Dude, I'll shave your leg for free.
A mí me gusta. A mí me gusta.
Alright. So, this is good. Right, so we put a patient on pulse ox, and then the first one she uses.
At least I'm wearing my uniform this time. I came in loud to my supervisor. I have my uniform shirt on. No, for national YouTube, you know what I'm saying? You don't look at me, you didn't shave while you in uniform.
Now try to breathe like calmly, right? So that we see, right? So what he has, right? He has the end-tidal CO2, but really what I'm going to do is I'm going to put it here in my mask, right? So you guys see the monitor, and you know what you're seeing, right? At the top, right, we see his EKG. At the bottom, we see his pulse, and the pulse ox is 98. He has end-tidal CO2 is 44. His respiratory rate is 18, and you see a good waveform, right? You see how these boxes are? This is real time. So every time I squeeze the bag, every time I do this, right, you have rise, right, like this box is going on, right? So we want the EKG, we want, right, the pulse ox, and we want the end-tidal CO2. And I usually turn on my audible alarms. I'm not going to do it now because I want you guys to hear. The next thing we're going to do is we are going to, right, we check their patient and we determine the indications. Failure to what? Maintain or protect. Failure to oxygenate or ventilate, and expect clinical course to decline. So you don't need all three, right? And what you're going to do is you're going to initiate your BLS procedures first, right? So let's say you will measure, right, the OPA, central incisors, angle of the mandible, and for this, I'm not wearing any PPE. What the PPE should be is gloves, face protection, and eye protection. Very important. Face protection, eye protection, gloves, right? Right? You're gonna open the mouth, right? And you're gonna insert the OPA, right? The technique I prefer is this. I just use my thumb to do this, and then I insert, and then I twist. Why do I do this? I don't want the patient to chomp down on my fingers, right? The next thing I'm gonna measure is my nasal trumpet, right? We said from what? From the nose to the, right? For these, you want a little bit of lubricant, right? You don't need a lot, right? Just a little bit, so it facilitates entry. How you insert it, right? Provide slight traction on the nostril. Don't push it back towards the head. You're gonna put it straight down, straight. 90-degree angle, right? The next thing I'm gonna do is I'm gonna initiate my BLS procedures, right? I'm just gonna have, since you're over here, come to the side. You're gonna be the person squeezing the bag, right? I connect it to high-con O2, I turn it on to 15 liters oxygen, right? And then, this is the technique I'm gonna show you. You spread the cuffs, you put the mask on the bridge of the nose, and you get a good seal. I'm then gonna find my ascending Remy, I'm gonna lift it and extend the head over the atlanto-occipital joint. But here's the trick, so that your hands don't tire out. I'm gonna engage on 5, and he's gonna squeeze on 6. So we'll squeeze on 6, and I'm gonna engage on 5. Squeeze. 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6. 2 1,000, 3 1,000, 4 1,000, 5, 6. 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6. So I'm gonna do this, right, for how long?
2 minutes.
What I'm doing at the same time, I'm looking at pulse ox and my end-tidal CO2. Every time he squeezes the bag, I expect that right square box. So I'm looking and listening, 2 minutes, right? Pulse ox what? 100. Right? Make sense? Right? So this is what I'm doing. I'm just going to show you the same procedure without the mask on. So what you're doing is you're going to find the ascending Remy, lift the mandle. You see what I'm doing? This is the jaw thrust. You're going to open the mouth and extend the hand over the atlanto-occipital joint. You're going to do this for 2 minutes. For this skill, if you don't do this for 2 minutes with the proper procedure, it's going to be a critical failure. We're going to practice doing it so you do it right. 2 minutes, you're going to practice, right? Stay here, right? I'm going to use you as my partner here. You're going to then prepare all your equipment. You're going to get your blade, right? I'm using here a mag blade. You have a Miller, right, which is a straight blade. I will tell you something that there's no such a thing as one blade for trauma or medical. You use the blade you're most proficient in. I'm most proficient in mag. I'm using that. So check your blade.
That was my question.
Yeah.
It doesn't matter, it's choice.
It's choice and your provider level of execution for it, right? How well you know how to use it, right? So, and then we said, right, we have to position. What the position should be? Sniffing.
But the book says not to use a curve for a child or an infant, only use a straight.
Yeah, for now we're gonna focus for an adult, right? So we're gonna say, what's the goal here? I wanna have the ear hole to the sternal latch, right? And then, right, so while this is being prepared, obviously we are providing ventilation, right? So maybe my partner is putting the padding on, right, and all the other stuff. Yeah, the next thing you're gonna need is you're gonna need your, right, and the tracheal tube straight to cuff, right? And you're gonna need your syringe, which is 10 cc. And I already pre-molded it, right, in the package, and I put some lubricant at the bottom. My partner over here is gonna hold it to the side, right? And, right, got my blade, and what I'm gonna do here, let me see if I have an extra one. I think I put it on the other bag, right? And what I'm gonna do is this, since I don't have it connected, I'm gonna connect my, what? Here. And title, right? That it's already here, right? Anyone on you have a stethoscope on person?
Yeah.
Yeah. Can I borrow it for a second? Oh, perfect. Right. I like the neon. Right. So stethoscope, right? And here I have my internal C2. I don't have it connected because I want you to see this number, but it's connected here. Pulse ox is on, right? So we pre-oxygenate this guy, right? And then I'm looking at the monitor. It's been 2 minutes, right? It's been 2 minutes. Pulse ox is 100, and I'm ready to go. If I had to push the drugs, right, before this procedure, I already did it. I have IV access in place in case patients decompensates. I say, Will, you got my tube ready, right? Hold this next to me like this. I get my blade out, and then I tell my partner, right? Let's say here, let me know when it's what, 92, but I'm also listening, right? So I take this out anatomically, right? I'm gonna use my, right, the technique to open it. If the guy in the cardiac arrest, yeah, you could do this cross finger, right? But I usually use my thumb. Come in from the side like this. We're gonna go slowly. I'm not jamming my blade all the way in. You're gonna inch on the tongue until I see the first structure is called epiglottiscopy. I wanna see the epiglottis. Once I see the epiglottis, I'm gonna slide my blade in the vallecular space. Once I slide my blade in the vallecular space, I'm gonna, you see how I'm not on the teeth? See how my motion is rock'em sock'em robot style, right? You see that? I'm not on the upper teeth. I don't have this. Breathe for me, sir. Breathe. I don't need you to. I take my tube. So this, right? If it was an 8.0, how far down I want to go? All right. You see that? 24 at the lip line, 24 centimeters. Everybody see that? Right? I still have my eyes on it. Right? I take out my blade. Right? I collapse.
Breathe more.
Is getting right. So take this out, and then what I do is I connect my what? I connect my entitle. This is very important step of the procedure. When I inflate this, I want to make sure I disconnect it right away. I don't let it go. This is a critical failure. Why? You see how the air went back? So once you inflate, you bring it to your finger and you do this. At this point, I'm locked in. My hand doesn't move until this is secured. I am locked in. So then my partner here has to, before we secure it, we have to confirm. How we confirm? Capnography. What's the number?
35.
Squeeze the back, sir. Right? Do I have chest rise? Right?
Yes.
But I'm not sure yet. I look at the number. Oh, it's 42. Squeeze. Am I in the lungs? Yeah. What's my pulse ox? 98. Right? So he's squeezing. Am I in the right place?
Yes.
I saw it go through the vocal cords. 35, 45, 99, 98, 99. Right? I'm not done. I'm not going to put it in my ears. You guys are going to learn to do this one-handed. So you're going to learn to open this up like this when you're doing this procedure. If you have a partner, right, he will assist you, and then you're going to put it in your ears. I'm going to put it on my neck so that you don't do it. So you open this up, put it in your ears. I said squeeze. And when you confirm, you don't have to squeeze one breath every 6 seconds. When I confirm, I want to do it quickly. Breath, breath. Breath, breath, right? Positive lung sounds bilaterally. Did I go too deep? No. If I was too deep, I will what? Deflate, pull back, reinflate, reassess what? Squeeze, squeeze, right? Very good. Am I confirm? Did I confirm?
Yes.
Right. So now what we're gonna do, this is called a Thomas tube holder. We're gonna secure our device in place, right?
What is it called?
Thomas tube holder. And I'm gonna show you, there's a few important things about it. This is a commercial holder. You could use tape, but for here, we're gonna use this device. So what you wanna do is you wanna kind of like thread it behind his neck. And then the next thing that I want to do is, you see, this is called the bite block. And you noticed, right? What is happening to my hand about this tube?
You don't
The hand doesn't leave.
Doesn't move.
The hand doesn't move. It's a critical failure, right? If you do. So what I do is I move it so that the bite block is going to sit in the mouth, right? I still don't secure it. This portion, this opening, has to go towards the feet, never to the top. Why? Because if I need to suction the mouth, the Yankee hour has to go through this. So this part goes toward the feet. Right? Then I lace this behind the head. Where's my hand still?
So
Did I secure the clamp? No, because I want to make sure the Velcro sits right. Right? This device they already used. There's usually like a longer strip on it that you could grab. It will facilitate ease of adjustment, but for now it's fine. Make sure both sides are secure. Once I'm comfortable with both sides, I then do what?
secure.
Secure, but not to the point you clamp it. Right? I want to have what?
Air.
Once I secure it, what do I need to do? Once I secure this,
Lung sound.
reconfirm everything. So what do I reconfirm? Entitle. What else? Long sounds. Right. What else? What else? Pulse ox. Everything. So from the start, the moment I resecure, 35, 45, 99%. Squeeze, squeeze. Anytime you move the patient, reconfirm. Anytime you do anything, you reconfirm. Right. So this is the procedure for the intubation. Right. I don't want to waste time in terms of the suction. They will show you how to do that, right? What I want to emphasize here, the difference between the old way and new way that you're going to do. You're going to do the triple airway maneuver. You're going to ventilate for 2 minutes, and then we want to see that. You're going to position. You see how I position the head, right? So we want to see that. Instrumenting the airway, right? Go by structures. Epiglottis first, vallecular next. Then you see the vocal cords, you put the tube in. Look at the number. How far down you're going, right? First confirm, secure, reconfirm. And then the instructor is going to tell you, right, if they have some secretions coming in, they're going to show you how to suction, right? I don't want to spend some time on that. When the patient is being transported on this, all of this is there. Any questions? Ask me now, any questions?
So it's going basically right up here when I'm doing it and then pushing down after. Okay.
How do we know like what size tube?
So for adult person, for an adult man, roughly 7 to 8, right? I want to get the biggest I can so that I have ease of air delivery. I don't want a short tube, right? There's a short diameter tube. It's not gonna give me as much air as this, right? You guys see the difference? Right? I have more impedance. I have more impedance. I may have my partner have 2 tubes ready by my side, and I may see once I go inside what I see.
Do you measure the tube?
The tube? No,
Is there a
no.
way to do that?
Yeah, you will see once you go in.
Okay.
They tell you that, but it's usually, from my experience,
Okay.
it's never worked out. So have a couple of them ready, but for adult male, I'll put probably 7.5 and 8.0.
Okay.
Any other questions?
So there is no measuring mechanism for
For this, yeah, once you open up, you got to look at what if they have some spasm and you see just a little bit, I may try smaller size.
Okay.
Couldn't you also mark the tube of where it's at?
Can you mark it? Right, I hold it at 23. You're going to document on your ACR. But when I go back, let's say this was cardiac arrest, firefighters bring them down, I open this up, I recheck everything. At the lip line, end-tidal CO2, right, pulse ox, lungs, everything. Any movement, I recheck everything. I print the strip.
So right now, when you enter this tube, like you said, Nick, that's the reason for positioning because that's
Because I want to align the oral axis, pharyngeal axis, and laryngeal axis. If I don't put this in this position, I cannot see it as well. I cannot see that.
Sorry, whoever's behind you. Okay.
Jordan, can you move the slides back a couple? Can you move the slides back a couple? Yeah. Push back. On the keyboard. Yeah, go back more. Stop right here. I want to see this structure. You see A? If I don't put them in this position, I don't see A. I may see something like this. I want to see A. Yeah. Anything else?
You said for like structure C, it's a whole different thing we would use, right?
Yeah, for structure C, yeah, we're going to get to that. We haven't learned that.
No, I just want to know for that one.
When you move him from your stretcher to the hospital journey, make sure you reconfirm it and get the doctor or the nurse to witness it. Because what's going to happen is they're going to move the patient, the tubes are going to be dislodged, and they're going to blame you.
Exactly. When I was working as a paramedic, I did that all the time. You have a patient who you tube, or interfacility transport guys on the tube, right? You do a transfer from your stretcher to theirs. This is what I do. I come in, right? I don't know if I have paper here. Let's see. I don't have paper. So what I will do is I'll print the strip out, right, at the time frame, right? You see how it marks? I will come over to the bedside. Say, who's the attending? Who's going to be taking care of this guy? Or they say, this Dr. Smith. Dr. Smith, can you come over here? Dr. Smith, while he's on our stretcher, right? We transferred him. Pulse ox reads 99. End-tidal CO2 is this number, right? And this is the strip. Can you please sign? I put Dr. Smith at the bedside of the transfer. If he doesn't sign, I will write the name of the doctor, and my partner will witness it.
Okay.
Because there's very hard to go, and then go into my report. It's very hard to argue the tube was not in the right place when you got the doctor's name at the bedside and at the time of the transfer.
Okay. So any type of movement, any type of thing,
you got it.
recheck everything.
What happens if the first thing that you know what the ER does? You bring a patient like this in. You know what they do? The doctor takes his laryngoscope. He checks where the tube is.
Where's that?
Any hospital you bring it to the ER, they take their video laryngoscope and they check where the tube is. They want to make sure it's in the vocal cords. And if it's not, it's on you. Right? You can lose your certifications for this. There's doctors actively putting out studies to take away this skill from you.
So you want to make sure everything is.
Yeah. Any other questions? No questions? Thank you, sir. You could remove it. I appreciate it.
Jeez, I had 0. I'm not breathing.
Thank you, by the way.